This presentation aims to provide a basic understanding of intracranial aneurysms. To understand intracranial aneurysms, we have to know the brain circulation. The anterior circulation consists of branches of the internal carotid artery. The ICA enters the cranium through the carotid foramen. It courses forward through the cavernous sinus. It enters the intradural compartment through the dural ring. Soon after that, it gives off the ophthalmic artery. Then we have the posterior communicating artery and the anterior choroidal arteries. After this, after giving off multiple perforators, the internal carotid artery divides into the anterior cerebral artery and the middle cerebral artery. The anterior cerebral artery gives off branches like the anterior communicating artery, which connects with the opposite anterior cerebral artery. There are also frontopolar and callosomarginal branches. The middle cerebral artery passes through the sylvian fissure and bifurcates into a frontal branch and a temporal branch. Sometimes we have a trifurcation instead of a bifurcation. The posterior circulation is constituted by the two vertebral arteries which arise from the subclavian. They pass up through the foramina transversoria of the vertebrae and enters the cranial cavity through the foramen magnum. The vertebral arteries each give off a posterior inferior cerebellar artery. Then the two vertebral arteries unite in front of the brainstem to form the basilar artery. The basilar artery gives off two anterior inferior cerebellar arteries, or the ICAs, and two superior cerebellar arteries, or the SCA. The basilar artery then divides into two posterior cerebral arteries. Now we have the circle of Willis, which is completed by two communicating arteries. The ACOM, or the anterior communicating, connects the right and left anterior cerebral arteries, and the PCOM connects the internal carotid artery to the posterior cerebral artery. Aneurysms are outpouchings of the vessel wall. There are two etiological factors. The first is a defect in the vessel wall. Normally, the vessel wall has got an intima, a media, and an adventitia. A defect in the medial or muscularis layer can result in an aneurysm form. The second factor which contributes is flow related. Aneurysms occur at bifurcations of vessels. There, a jet of blood impinges upon the crotch, resulting in an aneurysm. Aneurysms can also occur with high flow. Feeders to arteriovenous malformations, for example, may develop aneurysms. Classical aneurysm sites include aneurysms on the ICA, that is the ophthalmic aneurysms, posterior communicating aneurysms, anterior choroidal aneurysms, and ICA bifurcation aneurysms. Aneurysms on the anterior cerebral artery include ACOM, or anterior communicating artery aneurysms, and distal ACA aneurysms. MCA bifurcation is another site of aneurysms. Aneurysms arising from the vertebral complex are usually pica aneurysms. Aneurysms arising from the basilar artery include ICA aneurysms, SCA aneurysms, and top of the basilar aneurysms, where the basilar bifurcates into two posterior cerebral arteries. The classical presentation of an aneurysm is when the aneurysm ruptures. This does not mean that all aneurysms rupture. Only a small percentage of intracranial aneurysms rupture. When rupture occurs, however, you have subarachnoid hemorrhage. A very minor subarachnoid hemorrhage might precede an actual aneurysm rupture. These bleeds are herald bleeds or sentinel bleeds. Only a minor headache may be present. As aneurysm rupture, the gradation of severity is usually quantified either by the Hunt and Hess scales or the World Federation of Neurological Surgeons scales. These scales show aneurysm ruptures as graded from minor ruptures with only headache to severe ruptures where the patient presents moribund in coma. Radiological grading of aneurysm ruptures is by Fisher grades, depending upon the quantum of blood in the subarachnoid space and the presence or absence of intraventricular bleeds. Aneurysms may also present with cranial nerve syndromes. The classical cranial nerve syndrome is when a laterally pointing posterior communicating artery presses upon the third nerve, resulting in a third nerve palsy. This might occur before aneurysm rupture. Mass effect can also occur when a giant aneurysm presses upon the brainstem in the posterior fossa, or also other giant aneurysms. Clinically, subarachnoid hemorrhage results in immediate headache, which is severe, often very severe, and described as the worst headache of the person's life. Vomiting may be present. There will be either loss of consciousness or impairment of consciousness. In major ruptures, the person might move into coma. Neck pain because of meningism is present. Delayed clinical presentations of an aneurysm rupture include vasospasm, delayed vasospasm, which occurs because of blood in the subarachnoid space. Delayed vasospasm usually occurs from day 4 and may be present up to 3 weeks. Seizures may be present. Hydrocephalus may occur because subarachnoid hemorrhage might result in clogging of the arachnoid granules, which absorb CSF back into the venous stream. Electrolyte disturbances which occur with aneurysm rupture include syndrome of inappropriate ADH secretion or cerebral salt wasting, both of which result in hyponatremia. SIADH has increased fluid retention, while cerebral salt wasting usually results in a depletion of the intravascular compartment. Diabetes insipidus, characterized by a high urine output and an increase in the serum sodium, may occasionally occur in severe aneurysm ruptures. A CT scan is usually the primary investigation done in a case of subarachnoid hemorrhage. Subarachnoid hemorrhage in an aneurysm rupture is usually basal. The pattern of blood in the basal cisterns may reflect the direction and the degree of rupture. It shows probably the location from which the aneurysm has ruptured, and also it might reflect the configuration of the cistern. Acromenurism ruptures may result in interhemispheric blood, gyrus rectus hemorrhages, and maybe intraventricular bleed, depending on the direction in which the aneurysm is pointing. MCA aneurysms may present with blood in the sylvian fissure, in the basal cisterns, or even with intracerebral hematomas, often in the temporal lobe. PCOM aneurysm ruptures may actually rupture into the fourth ventricle. Others usually have basal subarachnoid hemorrhage. A CT angiogram will show aneurysms, cerebral aneurysms. MR angiogram is not as clear as a CT angiogram, but may be used when Contrast is contraindicated as in patients with renal dysfunction. The diagnostic modality of choice is a digital subtraction angiography or a catheter angiography. Transcranial Doppler is an investigative modality which can show blood flow velocities, which are an indirect marker of vasospasm. Management of an aneurysmal subarachnoid hemorrhage aims to minimize the consequences of the bleed and to prevent complications. The most devastating complication of an aneurysm rupture is a rebleed, which is associated with an extremely high mortality. Rebleed prevention ultimately requires blockage or clipping or coiling of the aneurysm. We'll discuss that soon. The second complication is vasospasm, delayed vasospasm. IV fluids, which are normally given, is normal saline. The older concept was to give triple H therapy to prevent vasospasm from occurring. This included hypertension, hypervolemia, and hemodilution. However, triple H is not used conventionally nowadays. Blood pressure maintenance of a systolic BP of around 150 millimeters of mercury in an unclipped aneurysm and 180 millimeters of mercury in a clipped aneurysm is recommended. Tranexamic acid may help in the prevention of a rebleed while we are waiting for definitive management. However, the use of tranexamic acid has been described to result in an increased incidence of hydrocephalus. Anti-seizure medications are routinely used. The patients have severe headache and require analgesia. Here, non-steroidal analgesics like aspirin are contraindicated because of their antiplatelet effects. Opiates are often used, tramadol, along with emisate, because tramadol results in vomiting often, and this might result in straining and an increased propensity for an aneurysm to rupture. So tramadol with emisate may be used. Sedation with a midazolam infusion is often desirable as the patient may be agitated. Nimodipine helps in the prevention of vasospasm and also acts as a cerebral protective. Definitive treatment of an aneurysm is the obliteration of the aneurysm. This will prevent a rebleed. There are two broad ways in which this can be achieved. The first is surgical. Surgical clipping involves a craniotomy. A pterional craniotomy is used for most anterior cranial fossa aneurysms. Anterior circulation aneurysms can be accessed by a pterional craniotomy, except for some DACA aneurysms, which might require a different approach. Pterional craniotomy can also be used to address top of the basilar aneurysms. A Sylvian fissure split is required to access the circle of Willis. After the vessel is exposed, a proximal control is obtained by a temporary clip, while the aneurysm is dissected free from the surrounding vessels. A permanent clip or multiple permanent clips are required to reconstruct the vessel and obliterate the aneurysm. Endovascular coiling involves packing an aneurysm with coils to obliterate its lumen and promote thrombosis of the aneurysm. Flow diverters may be used when endovascular coiling is not possible. This takes away the brunt of the flow from the aneurysm and results in thrombosis, decrease in size, and later probably thrombosis of the aneurysm. A quick talk about the highlights of this presentation. Cerebral aneurysms occur at branch points of the circle of Willis. Etiological factors include medial, that is, muscularis defects, and flow characteristics, where a jet of blood impinges upon a vessel bifurcation. The risk of a cerebral aneurysm is the risk of aneurysm rupture and subarachnoid hemorrhage. The clinical severity of a subarachnoid hemorrhage varies from relatively mild headache to severe obtundation and coma. Primary evaluation of an aneurysmal subarachnoid hemorrhage is by a CT scan of the head. CT angiography reveals cerebral aneurysms. Digital subtraction angiography is the gold standard for evaluation. Complications of aneurysmal subarachnoid hemorrhage include rebleed, which is a devastating complication, delayed vasospasm, seizures, hydrocephalus, and electrolyte derangements. Management of an aneurysmal subarachnoid hemorrhage aims at preventing complications. Definitive management aims to obliterate the aneurysm. This is done either by craniotomy and clipping or by endovascular coiling.